This discussion will focus on the basic assessment of the mitral valve. We will cover anatomic two-dimensional assessment and color flow assessment of mitral regurgitation and stenosis. In considering the mitral valve, equal attention must be paid to the structure and physiologic environment. Structurally, the mitral valve is comprised of leaflets, chordae, the annular tissue, and papillary muscles. From a functional standpoint, rate, rhythm, preload, afterload, and contractility are the considerations. In this series of images, we see a normally functional mitral valve with a normal plane of coaptation and leaflet mobility. The imaging planes here are the mid-esophageal 4-chamber, 5-chamber, 2-chamber, and long axis. One relationship to focus on is the appearance of the anterior leaflet in close association with the aortic valve and outflow tract. In this slide, we first see the commissural view, which has the anterior leaflet in the middle, wrapped by the posterior leaflet at the edges of the screen. In the second image, we see a 2-chamber view. Both demonstrate an even plane of coaptation and good leaflet mobility. This series of images demonstrates 3 of the cardinal imaging planes for the mitral valve. To the left of the screen, we see a mid-esophageal 4-chamber view with the anterior leaflet to the left and posterior leaflet to the right. On the right of the screen, we see a commissural view with the zoom added to demonstrate more clearly the dual coaptation points on the mitral valve. In this view, the A2 leaflet is in the middle of the screen and the posterior leaflet appears on the sides. The image to the bottom of the screen is a mid-esophageal aortic valve long axis view, which shows the posterior leaflet to the left or inferolateral side and the anterior leaflet to the right or anteroseptal side. In the simulator view, you can observe the heart from the transgastric perspective as the probe is advanced into the stomach and antiflex to reveal cuts through the short axis of the left ventricle. As the image develops and the heart is sliced more toward the base, notice the papillary muscles and chordae as they arise from the left ventricle and interface with the mitral valve. The image on the right shows an echocardiographic view of the mitral valve in the transgastric basal position. In this view, the posterior leaflet appears on the right of the screen, while the anterior leaflet appears to the left. Note that the posterior leaflet takes up more of the annulus, while the anterior leaflet takes up more of the interior of the mitral inflow tract. Coaptation defects can often be identified in this view. Color flow Doppler can be added to identify the origin and severity of a mitral regurgitation jet. This image is a transgastric long axis view of the left ventricle. The mitral valve appears to the right of the screen, with the chordae and papillary muscles arising from the left ventricle and inserting onto the inferior surfaces of the valve. This view is useful for assessing the papillary muscles and chordae. As a reminder, the mitral valve not only has to be competent in systole to avoid regurgitation, it also has to allow unrestricted flow in diastole to provide left ventricular filling. Dysfunction usually leads to regurgitation through the mitral valve, but thickening and poor mobility can cause stenosis. Note that systolic color signal through the valve in systole is consistent with regurgitation, whereas diastolic color signal is consistent with mitral stenosis. We will now discuss all the general classifications of mitral valve dysfunction as outlined in the Carpanthia system. A type 1 lesion has normal leaflet motion, suggesting either annular dilation or leaflet perforation. This leads to a central jet of mitral regurgitation. A type 2 lesion is due to excessive leaflet motion, such as a myxomatous leaflet, flail, or prolapse. In this case, the color flow goes away from the direction of the lesion. A type 3 lesion involves restriction of one or both leaflets. When a leaflet is restricted, the regurgitant flow is toward the direction of the lesion. Here we see classic examples of the two common type 1 lesions, annular dilation and leaflet perforation. Annular dilation typically occurs due to ischemia or volume overload. Leaflet perforation usually occurs due to endocarditis or iatrogenic injury during a procedure. Type 2 lesions of excessive leaflet motion are seen here. On the left, a classic Barlow's deformity is seen, with thickening of both leaflets and bileaflet prolapse. On the right, we see a fibroelastic deficiency with posterior leaflet flail. Note that the tip of the posterior leaflet extends above the annular plane, making this a flail as opposed to prolapse. A torn choroid can also be seen attached to the flail leaflet at end systole. The regurgitant jet would flow away from the leaflet prolapse. Here we see another example of excessive leaflet motion or type 2 lesion. This demonstrates a typical appearance of anterior leaflet prolapse. Prolapse is defined as displacement of a portion of a leaflet greater than 2 mm above the plane of coaptation. Type 3 or restrictive lesions are demonstrated here. On the left, classic thickening and a hockey stick deformity of the anterior mitral leaflet are seen. It is important to remember that mitral regurgitation is often coexisting with rheumatic mitral stenosis due to malcoaptation of the mitral leaflets. On the right of the screen, we see ischemic restriction of the chordae and papillary muscles, leading to a plane of coaptation below the level of the annulus and an obvious coaptation defect. A note about mitral stenosis that is worth considering is that it is frequently associated with high left atrial pressures and low flow, which can lead to left atrial appendage thrombi. Careful evaluation of the left atrial appendage includes visual assessment and pulse wave Doppler. In the image on the right, we see a large thrombus in the left atrial appendage. Note the way the color is changed to enhance the contrast between the appendage and the clot. Significant mitral regurgitation results in active blood flow in the left atrium and is thus protective against left atrial thrombus formation. In significant mitral stenosis, the left atrium becomes pressure overloaded and pulmonary hypertension results. This can lead to right ventricular hypertrophy, failure, and functional tricuspid regurgitation. The most common tool for assessment of mitral regurgitation is visual grading. It is important to apply color Doppler in multiple views to fully assess the degree of regurgitation. The extension of the jet into the left atrium, the width of the jet, and the amount of the left atrium that the jet consumes are some of the factors to consider during visual assessment with color Doppler. On the top left, we see trace regurgitation with a tiny color jet. On the top right, we see a mild jet with a narrow neck and a penetration just past the midpoint of the right atrium. On the bottom, we see a jet which hugs the wall, forming a coanda. These eccentric jets are very difficult to assess, but one factor is how far they wrap around the walls of the left atrium. In this case, the jet wraps all the way to the top of the left atrium, making it severe. It appears to be caused by anterior restriction, as the jet is directed toward the anterior leaflet, but could also be due to posterior prolapse. Further assessment is required to determine which is the cause. The most consistent way to assess the degree of mitral regurgitation is the use of the vena contracta. It is a measurement of the narrowest portion of the jet as it passes through the mitral valve. It is reproducible and relatively load independent. Less than 0.3 centimeters is considered mild, while greater than 0.7 centimeters is considered severe. This is an excellent example of a mixed regurgitant and stenotic lesion of the mitral valve. In systole, we see a large jet billowing back into the left atrium, which would be at least moderate or moderate to severe in intensity. In diastole, we see a hemisphere of flow acceleration above the mitral valve, which is strongly suggestive of mitral stenosis. The same findings can be seen both in the mid-esophageal aortic valve long axis view and in the four-chamber view. When the vena contracta is measured, it is 4.6 millimeters, suggesting a moderate to severe jet of mitral regurgitation. We will now move on to the discussion of mitral stenosis. In this mid-esophageal two-chamber view, we see a heavily calcified and poorly mobile mitral valve. Note the shadowing, which makes it very difficult to see the ventricular function below the valve. While a normal mitral valve measures 4 to 5 centimeters square, a severely stenotic valve measures less than 1 centimeter square. Here we see a heavily calcified and immobile posterior leaflet with spontaneous echo contrast, also known as smoke, in the left atrium. This sluggish flow is consistent with significant mitral stenosis. This image shows a significantly dilated left atrium and rightward deviation of the interatrial septum, suggesting pressure overload of the left atrium. The final image in this series shows echo contrast in the left atrial appendage. The brightness in the left atrial appendage is also suggestive of a possible clot. Low flow caused by mitral stenosis can lead to appendage clots, so a thorough exam should be conducted to evaluate for these. This series of images demonstrates another case of mitral stenosis. First, we see thickened and poorly mobile leaflets with a large left atrium. Next, we see a hemisphere of flow acceleration on the left atrial side of the mitral annulus in diastole, and turbulent transmittal flow, also suspicious for mitral stenosis. Finally, using continuous wave Doppler, a pressure half-time measurement is obtained, showing a mitral valve area of 1.13. Since severe mitral stenosis has a valve area of 1.0 or less, this is consistent with borderline severe mitral stenosis. This slide illustrates again the two-dimensional and color flow evaluation of the stenotic mitral valve. Again, there are poorly mobile leaflets on the left. The color flow exam shows mixed regurgitation and stenosis on the right. Having reviewed both mitral regurgitation and stenosis, it makes sense to review a few other key considerations in the assessment of the mitral valve. The first is the idea of systolic anterior motion, or SAM. This results from the mitral valve anterior leaflet obstructing flow through the LV outflow tract in systole. Here we see a terrific example of the anterior mitral leaflet hanging down into the outflow tract. When this happens, the treatment is volume and rate control as opposed to pressure treatment. One other essential idea to understand in assessment of mitral valve suitability for repair is the AL to PL ratio. If the ratio of these leaflets is greater than 1.5, repair is favorable. If the ratio is closer to 1, that suggests that a repair may result in SAM. A final consideration is the distance from the coaptation point to the septum. If this distance is greater than 2.5 centimeters, there is less risk of the anterior leaflet obstructing flow through the LVOT in a mitral repair. In conclusion, we have reviewed the mechanisms for mitral valve regurgitation and stenosis. It is important to consider both the anatomy of the heart and the physiology, which can interact to result in mitral pathology.